So, good morning, my dear students. Jareen Sultan. Good morning, madam.
Yes, sir. Good morning,
Good
sir.
morning. Sorup Bhomik. Sorup Bhomik.
Good morning, sir.
Good morning,
Good morning,
Farid
sir.
Ahmed. So, we'll be discussing on distal radius fracture. In last class, we have discussed about the Galeazzi fracture and Montezer fracture. We are meeting after some time to discuss about the fractures in the distal radius. Okay. Now, this is one of the very common fractures we entertain. Get lot of cases in OPD as well as casualty also. So, fracture distal radius is quite common and quite common in particularly in elderly age group after falling on an outstretched hand. Today, we will be discussing about various types of fracture in distal radius. One, and out of this, which is common, we will be discussing more details on the common fracture, that is COLLES fracture. And then also, we will discuss about the other fracture as well. So, this is your distal radius. And you know, distal radius is along with the ulna. This is your radioulnar joint, and they used to form the ridge joint here. But this ridge joint is mostly contributed by distal end of the radius, scaphoid, lunate mainly. And this fracture is taking place, which we will be discussing, is in this area, the cortico-cancellous junction within 1 inch. And this is the commonest fracture we used to get while a patient is falling on an outstretched hand. So if you look at this, your ridge joint, you will find a relationship between this styloid process of ulna and this styloid process of radius. This is very important for us for the clinical practice also, that you will find that tip of the radial stylus process is down below, then that of your this radial stylus process is down below, then that will be ulna. This level, if you draw the line like this, you will find this is an important correlation which is important for us, particularly while doing the manipulation. So while doing the manipulation, we try to find out the relationship we achieve. Normally, the ulnar styloid process is a bit high, of almost half an inch high, than that of the radial styloid process, which is low. And this relationship is important for us. On the other hand, the articular surface of the radius is downwards. Downwards means down. Forwards means facing anteriorly and medially. So this is another thing. The articular surface of the ulna, radius, is not exactly, is downwards. This articular surface is facing somewhat anteriorly, one, somewhat medially, downwards, forwards means anteriorly and medially. This is important for us also to maintain the reduction. So these are the 2 to 3 things important in anatomical correlations, which are important for manipulations and acidic correction all after fracture. Well, so this is the things I already mentioned to you, these anatomical correlations and anatomical landmarks, which are important for us, particularly after reduction, that we try to maintain a shift relationship after manipulation. So this is important for us to have a good outcome after the manipulation. Now, while there is a falling outstretched hand, what are the common fractures may take place? The commonest fractures in this area is your COLLES fracture. The name COLLES is coming by the name of a surgeon known as Abraham COLLES. Abraham COLLES has described these fractures long back in the 18th century. Though at that time there was no X-ray available. So without X-ray also, he has described about these fractures, various types of your displacements, and also the outcomes long back. So before invention X-ray. Another fracture which we see is your Smith fracture. Smith fracture is same with that of the Colles fracture but reversing. So what happened? That in Colles fracture, the distal fragment usually goes posteriorly because falling on palm. While there is a slip, while you try to fall down, the body reflexly allow him to fall on the hand so as to save this face or important structure. This is reflexly happens. That is common thing, and that is why the fracture is the Colles fracture, the fragments goes posteriorly. But very rarely, of course, reverse things may happen where he is falling on this dorsum. So that is very uncommon, but the fracture level is same with that of your Colles fracture. So you can say the reverse Colles or Smith fracture. Barton fractures are intra-articular fracture, means fracture happening to the articular surface of the radius. If the anterior fragment is going, you say it is anterior Barton fracture. If the posterior part is fractured out, that is your posterior Barton fracture. Another thing is your CHAUFFEUR'S fractures. CHAUFFEUR'S fracture is also actually fracture at the base of the radial stylo process. CHAUFFEUR'S means driver. In other words, these are those who used to drive the majestic cars for the state's head. Those are CHAUFFEUR'S. Earlier days, these cars driver actually they used to run the car with a handle, starting with a handle, and this handles reverse back sometimes to cause this fracture. This is not very common phenomenon nowadays, but even then, this name implies CHAUFFEUR'S actually coming from that, and it is basically fracture at the base of the radial stylo process known as CHAUFFEUR'S fracture. Now, what is the definition of it? This is a very important thing, and you're supposed to know the definition of the Colles fracture. And sometimes it may be a question in your theory as well as practical also how to define a Colles fracture. Now, the definition is a fracture within 1 inch of the wrist joint. So, this fracture is taking place in a distal end of the radius within 1 inch of the wrist joint without injury to the ulnar stylo process. That means your ulnar stylo process may get injured or may not get injured. 1 point. Number 2 is the ulnar collateral ligament may be also injured. Ulnar collateral ligament is nearby this. You have the radial collateral ligament, you have ulnar collateral ligament that may get also injured sometime. Or sometime there is a triangular cartilage. This is your ulnar stylo process may be injured sometime, may not injure, and there is a thyroid cartilage which is locating here that may get also injured. So these combinations of the injury may take place or may not take place. So the fracture is taking place within 1 inch of the wrist joint, distal radius, with or without to the fracture to the ulnar stylo process, with or without ulnar collateral ligament injury, or with or without injury to the thyroid cartilage in an adult. That is important. After skeletal maturity only, you will have these fractures. Before skeletal maturity, we do not say it is Colles fracture, but invariably in this age group, epiphyseal separation take place rather than that of your fracture. So it is seen in case of your female most of the time because of the osteoporosis. The bone is weak enough so that a trivial fall may lead to a fracture, and this is quite common with the osteoporosis with male and female also, but females are more common victim. So mechanism of injury, as I said, is a fall on an outstretched hand. So what are the displacement? Once there is a fracture there, displacement, as I said already in the earlier class, that it is the fragment, the distal fragment in relation to the proximal fragment. What are the position of the distal fragment in relation to the proximal fragment? How it is displaced? So the proximal fragment considered to be anatomical or a normal one, and in relation to this proximal fragment, what is this position of the distal fragment? Whether it is going medially, posteriorly, laterally, then you say it is posterior. If it is going posterior to the proximal fragment, the posterior. If it is going laterally, you say lateral displacement, like that. So it is true that what are the common thing? The posterior displacement and posterior tilt means fragment may go posteriorly, or tilt means angulation. Sometimes see it may displace going shift, but angulation means angulated. So shift is shifting, angulation means angulation. Position is not changed, but it may get angular. This is called your shift or tilt. This is, we say, this tilt. So tilt and a shift is different thing. Shifting means shifting the position. Our tilt is a angulations. The fragments get angulated but may not shift. So that is the difference. So in the COLLES flexor, we used to get 6 types of displacement. One is called posterior displacement, posterior tilt. Another is called lateral displacement, lateral tilt. Another is called inflection, means going upward, or there is a rotation, supination and rotations. So there are 6 types of the displacements may be seen in case of your COLLES flexor, and it depends and depends. That can be depends. This relation, this displacement is expressed with the relative position to that of your proximal fragment. So clinical features are that once the patient is coming to you, necessarily patient will have pain, swelling, restriction of the movement, and a classical type of deformity is mostly seen is called dinner-frog deformity. See this shape of the, while it is more displaced. In the undisplaced flexor, of course, you may not get this sort of deformity, but classically, this is the deformity commonly seen while the patient is coming to your casualty or OPD after a fallen outstretched hand, and this looks like a dinner-frog deformity. See, this is the fork, so it looks, so that is said to be a dinner-frog deformity. So there may be questions, some MCQ questions sometime in your entrance or anywhere else. Where do you get dinner-frog deformity? In COLLES flexor or other flexor, you will say it is COLLES flexor. So dinner-frog deformity is commonly seen in case of COLLES flexor. So necessarily patient will have all these problems: pain, swelling, restriction of movement, crime, and if you look at this limb, you will find a classical deformity which is known as dinner-frog deformity. So necessarily, after a while, the patient is coming to you, go for the X-ray to confirm it. X-ray is basically rejoint, but it is essential to take the X-ray of the whole forearm, so as to exclude the possibility of injury to the elbow joint also. Sometimes, very rare conditions, you may get injury to the wrist joint, elbow joint also. But though primarily it is the wrist joint, one should take the X-ray of the whole forearm along with this upper elbow joint and the wrist joint. Now these are the X-ray. What are the X-ray? AP and lateral view. Most of the time AP and lateral view are enough, and it will tell us about the flexors and about the displacement also. What can be diagnosed in X-ray? Articular surface facing dorsally and neutral. Lateral view you can see. Lateral view you can face the lateral horizontally. So you have to go through the X-ray and analyze it. So treatment: if there is a fracture but there is no displacement, nothing to worry about. So one can go for the plaster in these situ positions and patient will be okay. But once there is a displacement there, then you need to do corrections. So displacement should be corrected with this traction and counter tractions, and you do the manipulations to correct the deformity you seen in the X-ray. So as I said, the common are posterior displacement, posterior tilt, lateral displacement, lateral tilt, all these things should be corrected with the traction and counter tractions and manipulation. So finally, all the palmar flexion, ulnar deviation. Normally this is the position of the plaster normally applied, but somebody used to go neutral also. But little bit of your flexion and ulnar deviation is good to maintain this reduction you achieve. So now we confirm the X-ray for after manipulation, see how much you have achieved it not. Then if it is okay, one can continue the plaster subsequently for a period of 4 to 6 weeks time. So 4 to 6 weeks time. But meanwhile, during the period of time, you encourage him always do the exercises, wrist, then also elbow and shoulder exercise. This should be done. He should not maintain this sling for a long time. We allow the patient to maintain this sling for only for 2 to 3 days, then remove it and ask him to do work. Sometimes they go paper works, sometimes a glass of water or small things they can do, not heavy work. But this should be encouraged to prevent stiffness, and that should be done for the elbow joint as well as the shoulder joint also. And most of the time, it needs around 4 to 6 weeks time to remove the plasters, and then we subject the patient for physiotherapy. So now next question is there, what is Smith fracture? As I said, a Smith is a reverse thing of a COLLES where the fragment is going anteriorly while it is falling on a dorsum. Normally people are falling like this, but here it is falling like this. So necessarily the fragment will be going anteriorly, and the deformity in this case, if you sign, is a spade deformity, garden spade, the conti you use in the garden. So that is your classical deformity you see in case of. Then in case of COLLES, you say it is a Dinaford deformity, but in case of your Smith fracture, you say garden spade deformity. Then again you have to go for the X-ray. See, it is most of the time the fragment is going anteriorly, so that is why it is a reverse COLLES fracture. In reverse COLLES fracture also most of the time can be managed with manipulations and the plaster applications. But in this situation, the plaster, in case of the COLLES fracture, we apply the plaster up to below elbow. But in case of your Smith fracture, we used to go for above elbow cast. So that is a Smith fracture, 2 3 lines, small thing, but you have to understand. Now another thing is the Barton fracture. Barton fracture is interarticular fracture actually. It is happening to the articular cartilage, articular distal areas. If the fragment is going anteriorly, you say it is anterior Barton fracture. If it is going posteriorly, you say it is a posterior Barton fracture. Since it is interarticular fracture, most of the time you need to do the alignment, and most of the time this Barton fracture needs surgery, the operative treatment. So you may need to operation because interarticular fracture is important that the fracture should be reduced nicely since it is involving the joint. So joint architecture design should be maintained with good reductions of the fracture, and though it can be managed plaster with plaster, but most of the time it needs a operative treatment with your plate fixations more, and antibiotics should be most of the time open and do the fixation. These are certain techniques where one can do. This is a pin fixation, and a fixator will be like for the tractions. Sometimes in case of interarticular fracture also, COLLES fracture one can do this sort of technique. Sometimes it is necessary which cannot be maintained with the plaster. So operative treatments are essential even in case of COLLES fracture also. The CHAUFFEUR'S fracture, as I said, is a very small fracture. Most of the time it can be treated conservatively because it is fracture is based on this styloid process. So that can be done, but if there is a displacement, one can do manipulations and pin fixations and the cable fixation sometime because of the fact it is an interarticular fracture. But if there is no displacement, can be managed conservatively. But if there is a displacement, one can go fixations with the cable fixation there. So what are the complications one can? Nerve injury very uncommon, though sometimes seen in case of median nerve which can get compressed injury because a fragment which is falling. Sometimes a problem penetrated later on road. So sudic osteodystrophy, this is an important thing where the patient is having very severe pain, sympathetic osteodystrophy, patchy osteoporosis of the bone and stiffness and the shining of the skins, and patient is very discomforting one, irritating pain. This is because of the complex regional pain syndrome or sudic osteodystrophy. Somebody said is a sympathetic osteodystrophy. So sometimes very rarely because of the injury to the ulnar collateral ligament or styloid process, there may be some sort of pain or instability in the ulnar style, or associatedly there may be very rarely carpal bone fractures may be there, but very rare condition. Rare conditions, carpal bone fracture may be there, but it's very rare. It is not commonly seen. But very rarely one can go for your tendon injury sometimes. Delayed and non-union are very uncommon because these bones are very soft bone. It is a cartilaginous bone, so union is not a problem. But male union may be there. Union in a angulations, deformity is a very common thing. Male union may be there, but the non-union and the delayed unions are not very common in case of police fracture. Non-union not common. It is unites, but it unites many times in a deformity. This is called malunion. So the stiffness is very common problems. It is stiffness of the hands, sometimes stiffness of the elbow. So the shoulder is quite common because the patients maintain this position like this, they don't do any exercises. That is why after manipulation, one should suggest, encourage the patients to do active exercise to prevent stiffness of the fingers, elbow, and shoulder. So thank you. This is a very important topic, and we have discussed this thing. And this is a very common problem you encountered in day-to-day practice of orthopedics. So you're supposed to know, and it is practically also important, and theoretically also important thing we have discussed. If you have any question, you can ask.